So the topic today I'm covering is basically psychiatry. So I'm gonna be starting from the very start. What are we going to ask in the history? We are going to ask for the introduction, like name, role, purpose, circumstances, limits of confidentiality. Then we have to ask about identifying like data, name, age, gender, living situation, like independent or with somebody for the sport, like for the social sport, if he needs or not, or if he's living alone or something. So then comes the marital status, then children, source of income, if he's financially independent or relying on somebody, on occupation, adjunct and outpatient, inpatient, referral source, and known and unknown to provider. So on the side there is written as screening questions for the major psychiatric disorder. So this is important. Have you ever feeling down, depressed, or hopeless? Do you feel anxious or worry about things? Has there been a time in your life where you feel euphoric, extremely talkative, and a lot of energy, and decreased level of sleep? Do you hear or see things that other people cannot? And have you ever thought of harming yourself or killing yourself? So these are the basic psychiatric questions we will all. Let's suppose if the patient came to you and they want to ask you to screen for the psychiatry, and so you have to ask these kind of questions, like basically you are asking about depression, if he's feeling down or depressed, anxious, basically generalized anxiety or any anxiety issues he having. And then comes the euphoria or talkative, basically manic episode or any mania. Then comes the hallucination, like seeing or hearing things. And then harming yourself or killing yourself, basically suicide. Then comes the basically psychiatric functional inquiry. This is very important. What are those? So we have to always exclude about mood, and then we always have to exclude if there is any medical problem, like if he's any taking any substance use, or if he's having any swear caxic condition, or any condition that is basically causing this kind of psychiatric issues. Mostly what happens is when somebody is having like electrolytes disturbance or something like that, he might feeling confused, so we can like mix up this situation with the psychiatry. So that's why we have to evaluate all the blood tests necessary to rule out about infection, because in the old people what happen is if they have infection, they can present as delirium. So those looks like a little bit more like schizophrenia, or having a patient which is basically having manic episodes. So we have to rule out all the infection and UTI, like basically urinary tract infection, or any electrolyte abnormality. Then we also have to rule out anxiety, psychosis, and safety. So this is basically MOPS. So coming back to the point, we were asking about identifying data. Then comes the chief complaints, like what brings you here, what are you need, what is your basically need, what's your like in patient's own word. So we have to ask in his own words, so he can simplify, he can simply tell you what he needs. Then comes his history of the present illness, like context, events, problems, stressors, losses, and changes. Then come the symptoms, like onset, duration, intensity, progression, fluctuating. Then we have to ask about ADLs, IADLs, and personal care. So this is just the basic questions we need to ask about everything: coping mechanisms, seeking help, and then prior experience, longitudinal course, and wellness, and then usual personality, and then concerns, willingness, hopes, and then expectations. So then comes the psychiatry. We have to ask about like those MOPs, mood, other like medical conditions like obsession or disorder eating, or any other medical problems. Then comes anxiety, like any panic attack, phobias. Then comes psychosis, like hallucination or delusions. Then comes the safety, like have you ever thought of killing yourself, or like any homicide, or any dependent, like baby on the children, or something like elderly, disabled, or pets, or driving issues. And then cooking and fires, because of like dementia, he might have this cooking and fires issue. So past psychiatry history is basically like, do you have ever been like diagnosed with any problem and have been ever admitted? Because what happens in the mania, people might be admitted to the hospital 1 or 2 times. So we have to always rule out about this episode, and any ever been hospitalized total, or how many days he had to stay into the hospital, then emergency, then suicide, then self-harming and aggression, and then pharmacological. So if they ask you to write down what one thing you will have to rule out, so basically we have to rule out suicide in every single patient, because this is kind of something which we cannot ignore. So we can ignore about the rest of the stuff, but we cannot ignore about suicide. Then comes the substance use and type: tobacco, cannabis, alcohols, and you have to rule out basically any substance which can cause CNS stimulation, and which can cause CNS depression as well. So there might be some different things we will see in the in the context below. Then comes like we have to ask about first, typical, last, and periods of the abstinence, then withdrawal. Maybe like patient is having it for so long and then suddenly now he stopped it and now he's having this symptom, so it might be the withdrawal. Then previous problems, like has he ever like counseling, like any detoxification program he went to, or any motivation to change. So then comes the past medical surgical history, allergies, then comes the medication, if he's on any medication that can cause hallucinations or stuff like that. Then comes the family psychiatry. So what happened is basically schizophrenia can run in the family, bipolar can run in the family, and sometimes depression can also run in the family. So we have to know about the family medical and psychiatric issues as well. Then comes is the past personal developmental history. We have to rule about the birthplace, immigration, family members, and history of verbal, psychological, and verbal abuse, prenatal, perinatal. And then comes the age 3 and middle childhood, and the late childhood, like they might have any problem, any bullying going on, so that might be the cause of depression. So in the late there might be having like alcohol or school. So we have to ask about every single thing in those particular age people. Then comes the sexuality, like maybe they having them some gender identity problem, like maybe sexual orientation issues and sexual functioning experience or romantic relationship, and all those things according to the age. So we have to rule out like maybe in this particular age they have different kind of problems. Adulthood, they might have like education problem or relationship, like maybe because of failing some exam or going through some relationship, he might have been having some depression or anxiety type issues. Then comes the hobbies, like we have to rule out the interest, and then source for of the meaning, and then strengths and accomplishments and aspirations. Then basically comes collateral history, we have to rule out the source. Then comes the mental status examination, where we check about like some patient came to you, what are we going to check? First of all, we're going to see the age, the posture, the eye contact, if he's confident enough or he's avoiding the eye contact, he might have some anxiety issue going on. Facial expression, he feels alert, the way he's wearing clothes, and his like way of looking, if he's healthy or not. And then distinguishing features, like he might be wearing some weird clothes. On the basis of that, we can see if he's having like some sort of like schizoaffective disorder. Or then comes his reliability, and then gait, and then psychomotor. Then comes the speech, we have to rule out like if he's having like maybe like hesitancy or fluency, or inequality or volume issues. Then comes the mood and affect, then we have to rule out like he might have been low mood or high mood. Then comes the affect, basically if he is basically reacting to anything, right? So emotional like responses, he might be talking and start crying in the middle of the conversation, so we have to rule out. And if he's basically like totally blunt, he was talking and then he's not giving any reaction. If he's stable, like he's glowing along with the way he's talking, he's giving the expressions. And then comes the mood concurrences, like along with that. Many physicians give the scale like 0 to 10, so basically according to that. Then comes the perception, we need to rule out like hallucination, illusions, depersonalization, and realization. Hallucination is basically something which is not present, but he's thinking that this is there, like visual, auditory hallucination, olfactory is basically belong to temporal lobe epilepsy. So we have to rule out always rule olfactory hallucination. Then comes is basically illusions, like he's like mistaking with something, like it happens to the normal people as well. Like some people is looking at something and is like, oh, that is not a stick, it's a snake. So that is basically illusions. Then comes depersonalization, like he's like changing in the self-awareness of some patient feels like it's unreal, it's like detached from his body. And derealization is something like which is present and he feels like, oh, I am like in the outer world, or like this world doesn't belong to me. Then comes on the side, there's like mental status exam. What we do is basically acceptive appearance. So basically all these things is written in the short form here: appearance and behavior, speech, emotions, perception, thought, content and process, insight and judgment and cognition. Then is basically MSC is the analog, and we do it to focuses on the current sign, effect, and then behavior and cognition. Then is the basically spectrum of the effect, like is it full, restricted, blunt, or flat. There is a poor correlation between the impression of the suicide risk and frequency of attempts. So basically, if somebody is attempting it again and again, it might be bipolar disorder or borderline disorder. So we have to always rule out, maybe this is something else going on, that's why he's doing that, or maybe somebody's trying to do some lingering or factitious. So we have to always rule out if the attempts is more than the actual risk of the suicide. Then comes the thought process and form, that is basically coherence, like incoherent, like it is associated with it or it's not associated with the problem. And he can distinguish, like he can distinguish between the problems. Then comes is the stream, like goal directed, circumferential, tangential, and then loosening of the derailment and association, loss of flight of ideas and word salad. Maybe he's like like speaking anything which doesn't make any sense, and flight of ideas, like he's saying like I'm going to be doing this, and then on the second thought he's saying like I'm going to be doing that. So this is happening a lot in mania. Then it's basically like association, like he's basically illogically shifting from one topic to another, like it doesn't make any sense. He's talking about his family, and then another point is talking about something else which is totally irrelevant. And then comes the preservation, basically repetition of the same verbal or the motor responses to the stimulus. Like basically if he's like looking at one thing and talking about the same thing again and again, again and again. Echolalia is basically repetition of the same phrases, like he is speaking something but he's saying it again. Let's suppose I am saying this, then I keep on saying this, saying this, saying this, saying this. So this is basically echolalia. Then comes the thought blocking, the basically struggle, cessation of the flow or the thought and the speech. So basically he couldn't think of anything. Then comes the clang association, speech based on the sound, such as rhyming and punning, like making same kind of sounds in the end of the conversation, like you in the poems, just like in the poems. Then comes is the neologism, basically use of the novel words, like those high qualified words you are using in a simple conversation language, basically existing word in the novel fashion, in a very like modified or very like a complicated form, so in a simple person couldn't understand, but this is very like high qualified form. So basically you have to remember all these all these definitions: preservation, echolalia, thought blocking, clang association, and neologism. Then comes thought content, major themes discussed by the patient, discuss suicidal ideation, homicidal ideation, preoccupation, obsession. We have to talk about all of these stuff. So we have to see, this is the definition written about that. So what is basically themes discussed by the patient, what is he talking about basically. Then comes his suicide ideation, if is having any thought, plan, intent, and we will definitely discuss more about suicide in the context below. Then comes the preoccupation, ruminations, reflection, thought at the length, not fixed or false. Then is obsession, like if you are being thought like being persistent with something, like you feel like you want to do that and you feel uncomfortable if you don't do that. That is basically cannot be stopped by the logic reason. He knows this is wrong. So what happened here is basically obsession keeps on making that person feel uncomfortable. He doesn't wash his hand, or if he doesn't move that particular thing, if the door is open and if you couldn't close the door, then that particular uncomfortable feeling is there that makes him want to do that, and again and again, again and again. So that is basically like common themes is basically contamination, order line, like things placing in one line, and sexual and basically pathological doubt, worry, and guilt. Then is magical thinking, superstitious, believe that the thinking sometimes that will make it happen. Normal in children's, because like children's used to like affiliate themselves with the fairy tales and stuff like that. So it's very common in the children's, but not in the older people. So idea of references, so similar to the delusions of the references, but less fixed. Then comes overvalued ideas, maybe unusual beliefs that are not for the delusional proportions. So overvalued ideas is basically thinking of something which is not delusional, which is not like it could be possible. It could be possible, but it's like overvalued, like you are thinking too much about something. First rank symptoms of schizophrenia is basically thought insertion, withdrawal, broadcasting, all delusions, like coming of something uncertain and you are like want to do those particular things, like kind of delusions about things. Delusions, now let's suppose about what is delusions. Delusion is something like false belief that is out of keeping with the patient's cultural religious background and is firmly held despite intra-controvertible proof of the contrary. So you have to be very, very clear about delusions, because it's kind of very important. You need to know all these rest of the stuff is dependent on this is really basics. So delusion is something like, let's suppose if a person is believing into one thing and you keep on telling them and even proving them, still he's believing that thing, and that person is, and that whatever belief is not making any sense. It doesn't have any religious background or is anything. So that person is basically having like, let's suppose uh, he is thinking that this is if he does this is gonna be happening, right? But that thing is, it doesn't happen, but he still keep on believing that. So that's basically delusion. Then comes an insight. We have to look into the insight ability to realize that they have a mental health concerns. So about the delusions, there will become a little side points. We will read more about delusions, and then it will be easy for you. So insight is basically, you have to look how much that person is aware about his situation and aware about the situations surrounding him. That is basically insight, like ability to realize that they have a mental health concern. So what happened is, here comes a scenario that a person came to you and he is explaining the situation. It means that person has an insight because he himself is aware of his mental health. But let's suppose if somebody's like, his wife brought him or his mother brought him, so it means that person itself doesn't have a self health in related concern. He doesn't feel like he has any health related concern. So that's why somebody else is bringing that person to get the medical attention. So it's very important. You need to know in the scenarios, it's very like small points that makes a very big difference. So you need to know what is basically they're given. So it's a basically health concern to appreciate its application, and it relates to the functioning and benefits of the treatment, none limited, partial and full. Then is basically judgment is basically what happened is recent behavior as they relate to safety, social functioning and treatment decision. Like if a person is able to make a judgment that this treatment is okay for me, and if I don't take this treatment, this kind of consequences will be happening to me. So he is able to make this kind of judgment. If he is aware of that, then it's totally good and okay. And there is particularly stuff like that in the ethics, how you will see the particular person's judgment. So we will read that in the ethics session. Then comes this cognition. What happened here is level of consciousness. We will check that the patient is alert, reduced or attuned. And then orientation, we will check the person is time, place, person. Like let's suppose a person is in just happen take just a operation happen, right? And then you ask the person if he's aware of the circumstances, if he's in the hospital, that kind of basically orientation. But in this situation, it's basically in the psychiatry people, because sometimes they don't even know where they are. So in the alcoholic people or something, all these situations we have to check their orientation. It is very important. Memory, we took the immediate, like recent or remote, like it's if it's he could remember what is going on. And then global evaluation of the intellectual, like below average, average or above average, or in patients with the personal education. Intellectual, like maybe attention, concentration, calculating, abstraction, language and communication. MMSE and MOCA are very important, and MOCA is the preferable one. So then on the sidebar, it's written cognitive assessment use MMSE to assess for the orientation. That's what we do. Cognitive assessment use MMSE to check for the orientation, memory, attention, concentration, and then language, and then spatial ability. So orientation we do is time, place, memory. We check for the, like if he could recall, and then attention and concentration, if he could listen and he could concentrate. Then is language for the comprehension, reading, he could understand, he could write, he could listen, and he could repeat, stuff like that. Then spatial ability, like intersecting pentagons, like he knows this is basically like, how to explain. So basically spatial disabilities like intersecting pentagons, like he could understand that ability. So then comes is basically gross screen for the cognition dysfunction. Total screen is out of 30. Like less than 26 is basically abnormal, 20 to 26 is mild, 10 to 19 is moderate, and less than 10 is severe. And the use of the differentiating. So basically spatial ability is somebody could recall or understand the reasons and the numbers and the visual spatial relationship among the objects and the reason and the spaces. So if he could know like why is this thing here and why is this thing used for, all those things. So basically this comes the spatial ability. Then is the key to differentiating between the obsession and the delusions. In that, obsession are usually dystonic, sorry, and while unwanted and non-fitting in the person's goal and self-image, while delusions are egocentric. So obsession is basically a person is aware of that and he is basically taking it. If you are telling that this is like not right, so he's taking it. So that's what is basically ego dystonic. Ego means like his person's behavior of accepting the things, right? So dystonic means like it's okay, my he will put his ego aside and accept the things. But what happens in delusions, you are telling that person, but this is becomes his ego. Now this is his ego thing, right? So he is unaware and unacceptable of those things which is not even present, and you are even telling them, even giving them proof, but still he is not accepting it. So this is the difference between delusions and obsessions. Then is basically delusions. So I hope this clears your concept of delusions. This is more about it, you need to know this much, you don't have to go into very depth. So then comes this delusion. Delusion is comes in the different points: persecutory, references, erotomania, grandiose, religious, somatic, and nihilistic. What is persecutory? Beliefs that others are trying to cause harm to you. Like it is just like persecution. If somebody is trying to harm to you, you believe that, and you are telling that person, just like delusions, you are telling that person that this is not right. He's your friend, or he's your somebody, or he's not even somebody who would like to harm you, right? But he is not willing to accept that particular belief. Like you are telling him this is wrong, but he's not accepting that. References, what happen is interpreting ordinary regular events as having like a direct reference to you. So if somebody, like let's suppose a celebrity go to some particular place and that person start referencing that celebrity came to meet me, but that doesn't make any sense. So, and you are telling that this is not right, but he's not accepting it. Then comes erotomania, like believe that another is in love with him. Grandiosity, that he or she has a special powers, talents, and abilities. Religious is belief of receiving instructions, powers from a higher being, so those things. Then is somatic, belief that you have a physical disorder. This is very common. Somatic disorder, this is basically what happened in this scenario. Somebody start believing that he has some sort of issue going on in his body. He start feeling abdominal pain. Let's suppose a patient came to you with abdominal pain. You have done a lot of tests, or some other doctor has done a lot of tests, and everything came out normal. So what is this? This is basically somatic symptom disorder. Because what happened is here is he's believing that he has some sort of disorder going on, but when you do the test there is nothing, and he is unable to believe that. And what happened here is it is making that now it becomes disorder. Why it becomes disorder? Because it is affecting his daily life. When something is affecting somebody's daily life, this becomes a disorder. It's no more delusion, or no more something like which is very superficial. Because when it start affecting your daily life, it is basically you have to look into this and start giving that treatment. Then it's basically nihilistic. Basically what happened here is believe that things do not exist and sense that everything is not real. Assessing insight and the judgment, acknowledgement of the symptoms as a departure from the safe line or the source of suffering, attrition of the symptoms or to illness, or acceptance as the explanation, the part of the process. Acknowledgement of the need for the treatment. Why are you in the hospital? Why are you taking the medication? Why would it happen if you stop taking it? Then is judgment. Can you observe from the collected history and the patient's appearance and actions, are they dressed appropriately? By looking at that person, you can see that if that person is dressed properly or acting properly, taking care of self, so you can make a judgment, like is he able to make his judgment or not. So those are the questions you need to see, or you need to ask while making your insight or judgment. You can just, by looking at that person, you can see if that person is okay or able to make his own decision, and by asking few questions you can check his insight. So that is about it. In the next I will try to explain more. I hope this clears your point, because this is very important and you need to understand every single point of it to get a more easy and very important grip of psychiatry, because everything relates with one to another. If one thing doesn't there, then it becomes the other disease. So you have to be very clear about those stuff, and those little calculations. So we will definitely try to discuss more about it. I hope that helps you, and if you have any questions, you can just comment in the chat below, and I will definitely love to answer in all those questions. And that's about it. So see you in the next session.